Thank you for inviting me to speak. So after that fantastic and fascinating trip across the therapeutic landscape for weight management, I'm going to focus more now on lifestyle interventions and those which I've had the opportunity to implement at scale across England. Okay, slides are advancing. Good. Now, I find it useful to conceptualize interventions in this space using this slide. And I think it's important to have a handle on the whole interventional spectrum, if you like. And on the left here, we start with population level interventions. These are often public health interventions, often implemented through legislation by national government. An example would be the sugar tax that was implemented on the 1st of April 2018, I think, whereby fizzy drinks attracted a higher cost for the consumer, and as a result, the manufacturers reformulated up to 2 years in advance of implementation of the tax. So calorie input via fizzy drinks was reduced. So the reach for such an intervention, which is the left-hand side of this figure, is massive. It's the whole population of England. 55, 60 million people could potentially benefit, but the effect size obviously is tiny. A few calories less a day, etc. But the unit cost is correspondingly similarly tiny, a couple of pence per person. Now, as you move to the other end of the spectrum, we have what I call individual level interventions. Now, these are obviously what the NHS does. It does stuff to individuals. And so this very much sits within our ball court within the NHS rather than public health or local government or national government, which is at the other end of the spectrum. And we can intervene with lifestyle interventions, which are relatively cheap, which allows us to get much greater reach for the same amount of money, but effect size is perhaps not as large as the extreme right-hand side here. And Tricia has beautifully covered the therapeutics, the amazing weight loss that we can see with these new agents. So big effect size, unfortunately matching equally impressive unit cost per annum for those drugs. Obviously, there will come a time when they'll come off patent. And if we look at bariatric surgery, for example, probably has the biggest effect size, as Tricia showed us, 20 to 30% body mass index, weight reduction rather, per individual. But the cost is huge, 7,500 for an operation, the effect size being massive. But the fact that the cost is so high, we do 5,000 operations in England a year for a substrate population living with a body mass index within the obese range of around 14 million. So we need, I was often asked in the national role, what is the silver bullet? And I would always say there isn't a single intervention. We want to pack our portfolio of actions with as many different approaches as we possibly can so that the sum of the effects is something worthwhile. And even for the drug therapeutics, which are now attracting so much excitement, many people want to try them. Not just for health reasons, that sort of goal of losing weight goes beyond health, I think. But when we look back at national diabetes audit data and look at people on GLP-1 therapy or have been prescribed it in the past, only around 50% are still on it at the 12-month mark. And there are significant side effects associated with these agents as well. So we need a bit of everything. But what I'm going to focus on today is the lifestyle interventions. I'm going to talk about 3 different programs that have been rolled out nationally that I had the privilege to, well, firstly, successfully make the case for investment in so that they could happen, then implementation at scale across England, and alongside that and subsequently the opportunity to use real-world data to evaluate the effects, to sort of deepen our understanding of implementation science that went along with implementation of the programs. Just to say, a common concern is that when you come off a weight loss program, I think Tricia used the term yo-yo up and down, and there is evidence of that. But if we take, for example, the earliest randomized controlled trial looking at an intensive lifestyle intervention to prevent type 2 diabetes, that was in China 30 years ago. The 30 years data it shows ongoing reduction in cumulative incidence of type 2 diabetes in those that had the intensive lifestyle intervention at 30 years, reduced cardiovascular events, reduced mortality even. So there are lasting effects. We're looking to augment the lasting effect with some research we're doing in collaboration with the University of Cambridge, looking at a follow-on intervention to sustain the weight loss achieved as people come off these national programs. But I'm going to talk in detail about the top one and then just mention quite briefly the other two. So the diabetes prevention program appeared. I don't know how many people on the call have been able to read at least the executive summary of the NHS strategy document that was published yesterday. Fit for the Future 10-year health plan for England came out yesterday. Well, I'm going back now to previous strategy documents. The 5-year forward view was published in October of 2014. Is it the right word? I pitched for inclusion in this strategy document an evidence-based national at-scale delivered type 2 diabetes prevention program. I made the case based on well-conducted randomized controlled trials on a number of continents. I've mentioned the Chinese one, but there are a number of others, all showing the potential to reduce type 2 diabetes incidence through intensive lifestyle intervention up to a cumulative incidence reduction of around 60%. So I landed it in the document. That was pre-election 2015. It got funded post-election, and we were able to implement. So just briefly, in terms of the stages of implementation, and we mustn't forget the importance of implementation. We have the North West London Applied Research Collaboration that takes the results of randomized controlled trials, takes good evidence, but actually studies the challenges of implementation. So what I'm going to talk about today is implementation at scale. So what the first thing that we did was establish an expert reference group, so some of the great and the good in terms of thinking around diabetes prevention around the country, a group that I chaired for the ensuing 9 years. We developed a service specification that described an intervention that we felt had the best chance of success within the live environments of the NHS in England. We used that service specification to run a national procurement exercise. We asked providers at procurement of the ability to deliver on the content of the service specification anywhere in England. We appointed 4 providers to the national framework, and then each local area had the opportunity to choose which of the providers on the national framework could best meet their local population need. The intervention itself that we landed on through best evidence reviews was a 9-month intensive lifestyle intervention, group-based face-to-face delivery, focusing on behavior, support for behavior change around losing weight, exercising more frequently, and improving quality of nutrition. So not rocket science, really, but that was the intervention. 9 months delivered over at least 13 interventional sessions, a minimum 16 hours of contact time. And we then rolled out over the subsequent financial years. First year of rollout was 16-17, and North West London was one of the first areas of the country to come on board and overperformed in terms of referrals in that first year. So thank you to anyone online who was involved in that overperformance. But we hit 51% geographical coverage across England in that first year, 75% coverage in the second year of rollout, and then by summer of 18, we became the first country internationally to implement at scale across the entire country such an intervention to prevent type 2 diabetes. Now, our providers don't get paid unless they populate a minimum data set on every participant every month. So we have amazingly granular data that we built from the beginning here. that we can link by NHS number to other national data sets, including the National Diabetes Audit, which includes everyone with a coded diagnosis of diabetes. But from inception of the programme, we expanded the National Diabetes Audit to extract data on everyone with a coded diagnosis of pre-diabetes as well. So we had all of the mechanisms in place in terms of measuring the success of our implementation using real-world data, electronic health record extracted national audit data. Our first paper published looked at equity of access, and as is the way with our general practitioners across England, fantastic at levelling up, if you want to describe it in that way, overrepresentation in referral cohorts from general practice of those from more deprived areas of the community, of our communities, and from non-white ethnicity, in particular South Asian, African and Caribbean communities, who we know have higher risk of developing type 2 diabetes in the first place. So a very good equity of access in the referral cohorts. We went on a couple of years later, looking at the first 350,000 people referred into programme at weight loss and HbA1c reduction trajectories, which I'll show you shortly. I thought it might be nice. I haven't shown this data before, and this is some ongoing work at the moment that is provisional, not yet complete, but this is actually looking at the individual area data from Northwest London. So who are the substrate population? They are people with prediabetes, as I've described. Another means of describing is non-diabetic hypoglycemia. 95% of people are defined to have non-diabetic hypoglycemia through HbA1c measurement, and a value between 42 and 47 millimoles per mole inclusive puts you in the category. 5% find themselves in the category through either fasting glucose level or oral glucose tolerance testing, but the vast majority via HbA1c. Now, in these panels, top left is age distribution, top right sex, ethnicity, bottom left, decile of socioeconomic deprivation is plotted bottom right. And what I've plotted here is the distribution of people living with prediabetes in the whole of England in the dark blue bars, and in Northwest London in the lighter bars. And some points to highlight. This won't surprise many on the webinar. We have a younger population in Northwest London compared to the rest of the country. I think many of us know that. And this is how it translates to our pre-diabetes population. Basically, we see a shift in the age distribution to the left by around 5 years. Ethnicity, obviously we have high ethnic diversity within Northwest London. Almost the proportion of people of white ethnicity living with prediabetes are almost half in Northwest London compared to the proportion in the rest of England. And the major groups, other ethnic groups constituting those with prediabetes are those of Indian and other Asian ethnicity. And as I think we know, the biggest groups, the ethnic groups, are those of Punjabi and those of Gujarati origin in the Northwest London sector. And I think the socioeconomic distribution graph on the right here at the bottom is interesting. We always see more in the most deprived living with prediabetes than the least deprived, which is the case in the darker blue bars for the whole of England. But the distribution in Northwest London for us of people with prediabetes reflects the distribution of socioeconomic status across Northwest London. We have less in the most deprived decile, less in the least deprived as well, with bunching up in decile sort of 2, 3, 4, 5, 6 really. So that is our substrate population for this. We have got provisional data which is looking like we are better at ascertainment of prediabetes status in Northwest London. We're referring a few more into the programme, and people are doing as well on programme. Just the suggestion that we may have a lower conversion rate to type 2 diabetes in Northwest London, but that's very provisional, and I haven't shown you those slides deliberately yet. The weight change that I alluded to, first 350,000 people referred in or so, is here. So the delivery of the intervention is via a minimum of 13 interventional sessions. And what you can see here in the panel is the beautiful dose-response relationship. The more sessions people attend, the greater the weight loss that they achieve, weight change on the y-axis here. If we define completion as attendance at least 60% of sessions, so for those that fulfill that definition of completion. Mean weight loss is 3.3 kilograms on programme. Intention to treat, so anyone who started, 2.3 kilograms. Corresponding numbers and graph for HbA1c changes here. Completer analysis, 2 millimole per mole reduction. Intention to treat, 1.3 millimole per mole reduction. Now, actually, when we first established the programme and procured our providers, there was some criticism, political criticism, actually, we do everything digitally now. Why haven't you put digital providers onto the national framework? And the truth was that we always said we'd follow the evidence, and the evidence for digital modes of delivery back in 2015 was fairly poor. But we did undertake to do an experiment, as it were, to pilot an intervention. We needed 3,500 individuals. We went through an elaborate selection process and worked with 5 digital providers, and we tested the effectiveness of digital modes of delivery, essentially. We've published lots on this, but there's a methodology paper here. There's the primary results paper here. We first showed non-inferiority of digital modes of delivery using weight change and HbA1c reduction as the endpoints. We then showed superiority. We had the results literally a couple of months before COVID and lockdown, and which meant we had the confidence to morph the programme during COVID into remote and digital delivery. And we've now had, getting on for somewhere in the region of 250,000 people attending digital interventions. And now we give people the choice when referred in to either attend a group-based face-to-face delivered session, sessional approach, or digital modes of delivery. I find this graph fascinating. I think this is a truism for digital delivery of most things in health, and there was a lot contained in the strategy document published yesterday. This is what you get. You see a shift in the age distribution by about a decade, or we have seen that in the diabetes prevention programme, in terms of who is attracted to digital modes of delivery compared to who is attracted to the traditional group-based face-to-face. The age distribution, you can see, a decade younger for those that choose digital modes of delivery. So lots and lots of data we could show. I thought I'd show you the equivalent graph using our own data. This is updated data, fairly recent data, whereby we look at everyone who's passed through the programme. We then follow them for 2 years using the national audit data, the national data sets with linkage to the minimum data set, to see who subsequently converts. And we can measure conversion rate to type 2 diabetes per 1,000 person years, which is on the y-axis here. And again, this beautiful dose-response relationship, showing that the more people attend of the programme, the less their subsequent conversion rate to type 2 diabetes, such that those that attend the whole offering reduce their incidence by around 50%. Not a little shorter than of the randomised controlled trial figure, but not far off. A lot of taxpayers' money has gone into this, tens and tens of millions, which means that we quite rightly required an independent evaluation, not just our own evaluation works, and NIHR commissioned University of Manchester. I've just given 2 of many of their publications. The top showed reduced incidence among those who complete versus not complete, reduced incidence of 30%. And the bottom one, which is particularly pleasing, they exploited the phased rollouts of the programme across the country in waves to show reduced incidence of type 2 diabetes at English population level as each area sequentially got access to the programme. They've also shown cost effectiveness by 12 months. They've shown cost saving by year 9. So this is, I'd like to say, a success story in terms of clinical effectiveness, cost saving now as well. Just in terms of, we modelled using Health Survey for England data that back in 2015, we estimated about 5 million people were probably living with prediabetes. We've had almost 2 million people referred in now. This is from inception of the programme, this is number of referrals per month, which is around 30,000 people with prediabetes now. And we're over 1.8 million people referred in. So real reach and scale of the programme, which we know now is effective. We hypothesised surely an intensive lifestyle intervention lasting 9 months, focusing on the things it focuses, Surely it's doing more than reducing incidence of type 2 diabetes was the question and the hypothesis. So this is a retrospective look. Just heard that this has now been accepted for publication in Nature Medicine, actually. So we took people who had passed through the program and completed, and we matched them for everything we could possibly measure, because we've got huge numbers to be able to do this now. We matched them for age and sex, ethnicity, deprivation, and quaff points, so the GP surgery looking after everything we could possibly measure. And we compared, in the top panel, incidence at 6, 12, 18, and 24 months after the program of newly diagnosed type 2 diabetes. But then we put together a number of other conditions, examples: hypertension, coronary heart disease, depression, to name a few, but we put a large bucket of other long-term conditions that could be said to be associated with potential benefits from weight loss, put it that way, and we see this signal of potential benefit. We are looking like we will have the opportunity moving forward to test this more thoroughly, prospectively, experimentally within 8 ICBs across England, one of which will be North West London. We'll look at a different cohort, a hypertension cohort, point them towards the same intervention, a 9-month intensive lifestyle intervention, and run it as a step wedge cluster randomized trial to see if we can prove a reduced incidence of these other long-term conditions, so potentially much greater gain, akin to the off-target effects of the drugs, perhaps. Anyway, just to mention the other 2 programs, the NHS Type 2 Diabetes Path to Remission program was based on the DIRECT trial published by Mike Lean and Roy Taylor in 2018. It took people with recently diagnosed type 2 diabetes within 6 years of diagnosis. It put them on a fairly draconian diet of total diet replacement for 3 months, so soups and shakes, as the Daily Mail referred to it as, for a 3-month period. Significant weight loss achieved as a result. And they showed they showed a remission rate, that's a normal HbA1c achieved off treatment, of just short of 50%. Delivery was by healthcare professionals in primary care, which is not scalable for a new lifestyle intervention program. But in the same year, fortunately, the Oxford group published the Droplet trial, same intervention, same weight loss achieved, with delivery by health coaches, so lay people trained up. And that gave me the ticket to make the case for inclusion in the next strategy document, the 2019 NHS long-term plan. We said that we'd pilot. We did pilot. It was successful. And then, using exactly the same model for implementation that I've described for the diabetes prevention program, we did the same for the remission program. We finished national rollout last April. North West London, for this one, actually, we're in the final wave. So in terms of, it's a 12-month intervention, so I can't show you any completion data yet for North West London. We'll be able to in the next few years. We've got 40,000 people now referred into program. This is the weight loss. So by the end of the soups and shakes diet, 13 kilogram average weight loss. Then there's food reintroduction phase, then maintenance of weight loss phase, and people's mean weight change from baseline to the 12-month mark is 10 kilograms. We published recently in Lancet D&E that the corresponding remission rate for those that had completed, that we had sufficient measurements on at that point in time, was 32%. So some attenuation, as one would have expect in effect size, moving from idealized environment of randomized controlled trial to the real world. Now, the last program is the NHS Digital Weight Management Program. We established this in COVID times during lockdown. It is entirely digitally delivered. It is for people living with a body mass index within the obese range, appropriately adjusted for ethnicity, who are living also with either hypertension or diabetes or both. We've now got 500,000 people referred in nationally. This was our first published output, just to show that from first year's cohort of 64,000, intention to treat weight loss 2.2 kilograms. And this is a much cheaper intervention with much greater potential for reach, and completer analysis weight loss 3.9 kilograms. So those are the 3 lifestyle interventions that we've rolled out nationally. We are seen by some as international exemplars in what we have done. This is work with Canada. This was published in the Canadian Medical Association Journal 2.5 weeks ago. So building diabetes prevention and remission of programs across Canada, learning from England. So I'm working with the team over there. in Quebec, actually, where they're looking to pilot it first. But thank you very much for your attention.